I don't want to volunteer to donate my organs because what if I'm in a heinous accident? What if I'm still alive? And now they're more worried about harvesting my organs as opposed to keeping me alive.
All these modalities, we're basically using a different type of tool to help release certain stress points or chakras or energy facilities. For acupuncture, we usually think of the needle. Another modality would be the cupping. You use these cups that will then, you heat it up and it will then suction out. Coining is even more interesting because you literally use a coin, so something like a quarter or a nickel, and you how do I describe this? You basically follow the lines of your ribs and your spine. Medicine,
Law, friendship. This is Dr. Long and Laura Nick. You're listening to the Medico-Legal Brief.
one doctor, one lawyer, and a whole lot of gray area.
Welcome back, everybody, to the Medico-Legal Brief, where medicine meets the law. We got Lawyer Nick here. I'm here with Dr. Long. And happy Halloween. We are doing a Halloween special, so we have some fun topics for the day. Today, we're going to cover 3 things that are based a little bit in urban legend, a little bit in myth, and a little bit of just history. We'll dive into that as well as organ donation and collection. The next thing that we're going to discuss is how do doctors pronounce individuals dead? How does a doctor determine that an individual has passed, and how that relates to 18th and 19th century safety caskets? And then the final item that we'll discuss today, the final topic, is going to be witchcraft and voodoo and how herbal supplements and potions have come to be, and how physicians in this day and age actually use herbal remedies and non-traditional remedies to help their patients. So the urban legend is that you go out for the night, you meet a girl, you meet a guy, you meet a friend, and you're having a good night. And you're either drinking or you're eating or you're partaking in other things. And before you know it, you black out and you wake up in the morning and you are in a bathtub. And in that bathtub, you are covered in ice. You're unaware of your surroundings. You don't know what's going on. You look down and you see stitches all across your side. You look to the left and sitting next to you, there's a note that says, call 911 now. And you realize that somebody has performed surgery on you. Somebody has stolen one of your organs. First question to you, Dr. Long. When you're looking at organs, when you're looking at the need for organs, what have you seen over your medical career as what's actually needed? What can you live with? What can you not live without?
So with the advancement of technology, the advancement of medicine, there's actually a lot that we can live without or live with partial of. So most of our organs we can actually live partially with. A lot of people out there only have one kidney. A lot of people out there only have partial pancreas, half a lung or part of a lung. Some people even live with just part of the stomach, right? That's a big weight loss surgery where it's bariatric surgery or getting some sort of alteration to your stomach. So there have been a lot of new surgical modalities, techniques, as well as new advancements that allow us to stay alive even when we don't have our full set of organs that we were born with. And even then, there are people who are born congenitally with missing organs and they are doing just fine. Obviously, there are more medical interventions that are needed. They may be visiting the doctors more often. They may be on certain medical treatments to prevent illness. So there's a lot that goes into not having the full set of organs that you would benefit from, but you definitely can still have a full, long life, even with just partial organs.
Now, from my understanding about, organ collection, organ donation, needing an organ, so on and so forth, like there's generally wait lists, there's generally expenses, like wait lists can be very, very long, expenses can be extremely, extremely high. So is that the case? Are there general wait lists for that? Or is it something that, depending on your certain circumstance, you can get something done really, really fast and get something done really, really cheap, taking into account who I guess is giving you the organ?
Taking one out of your book, Lori Nick, but it depends. So it really does depend on who's donating, who's needing an organ, what type of organ, and in what sort of situation are we needing that organ? Is it emergent? Is it urgent? Is it something that can wait? Is it something where you know the organ will fail in a couple of years, therefore you have time to look for it? Do we have a match? There's a lot that goes into matching organs. Not only does some of the genetic components have to come to match, but also you want to make sure the blood type. You want to make sure that the organ does not get rejected by the body. So there's a lot that goes into getting an organ, but there's even more of a process to get the organ match. And that's why there is always usually a wait list. If we are planning far ahead and we know that there is going to be an organ failure, whether that is liver failure because of hepatitis or alcohol use, and we already know that there might be a family member that could be a match, then sometimes we could set those things ahead of time. The benefit of living in the US is usually we have the volunteering or the opportunity to volunteer to be an organ donor. So that's something that you can elect to put on your driver's license. Or if you do not or forget to do so on your driver's license, you can opt to do that in the hospital if you know that you're going to be passing soon, or if you know that you have a terminal illness, or there's documentation there that you may want to designate at that point in time. And that will follow you through whether you come out of the hospital stay alive or not. At least we know your wishes there then and there. And that will follow you through your medical chart.
That's very good information. Let's say I'm about to have a child. So in the future, I need to give an organ to my child. I assume, based on what you're saying, there's a lot of tests to make sure that I'm matched and I'm compatible. Is that as prevalent as it sounds, like in which a family member is giving another family member an organ? Like, is that one of the first things that you guys are looking at to see, hey, we need an organ, let's just look at the family, look at it because that might be an immediate match?
Yes, we're more likely going to look at the closest relatives first. So that's going to be siblings, kids, parents as our go to. If they consent, then they get tested. If they do not consent, there are a lot of family members out there who do not want to give their organ or want to be a part of that process. Then we then have to go to the actual registry, and there are registries out there for hearts, lungs, livers.
And I assume there's a standard for this registry. It's not like anybody can just roll up and say, hey, can you take my liver?
Correct. Again, luckily here in the US, it's a volunteer basis. It's not something where you could be coerced or be forced to give up an organ. So the people on the list who are wanting to give out their organs have consented when they were living or were consented by a power of attorney who have allowed those organs to be released to their recipients. In terms of the recipient, the person receiving the organ, there are a lot of different criteria that they have to meet. So someone that has liver failure, we got to make sure that they meet certain vaccination guidelines because we want to make sure that if they are going to be getting an organ that there's not going to be any reason for that organ to fail. We're trying to limit or decrease the risk of that organ being rejected. So we type and match everything. So they always got to make sure that the blood type, the genetic code, all of that matches as closely as possible. It's never going to be 100%, but we can get it as close as possible. Other things are we want to make sure that whatever caused the liver failure to occur in the first place, so whether that is due to an infection like hepatitis, we want to make sure that that has been treated. Or if this was alcohol related, you want to make sure that they have abstained from alcohol use and that they've shown success in maintaining that abstinence. Otherwise, if they end up picking up drinking again, then there goes another liver. So that goes for any sort of organ in the system, including kidneys, lungs. If they're a smoker, we want to make sure they have completely stopped smoking. Or if they are exposed to a certain thing, that they are removed from that exposure in their environment so that they don't then re-injure the new organ that they have received. Now, that is a very small part of the process. The other process is a lifelong process, which is taking lifelong medications to help suppress your body's natural immune system, which is it's going to want to reject these organs, whether it's compatible or not. It's always going to want to try to reject it. Just like anything else that you put into your body, stents for your heart. If you ever had a heart attack and you put stents in your vessels, your body's going to want to try to reject that. And so there are medications that you will have to be on lifelong to prevent or decrease the risk of those rejections.
I think that when you're hearing the stories of organ donation or transplants or what have you, you're looking at the individual who's sick. Whether it's a movie, whether it's a book, whether it's real life, the story shows somebody struggling with an illness, somebody gets sick, somebody comes in and helps save the day. The thing that the media never really covers is what happens to the donor. So if I'm a healthy individual and I donate one of my organs to somebody else, how does that impact my quality of life for the future? Because obviously I'm helping to save a life, but I would assume that I would face some sort of inconveniences as I age and so on and so forth?
When it comes to a live donor, a donor that is giving just a portion of an organ or just one of their kidneys, they usually have to understand the ramifications, which is really all more short term. So if you were to donate a kidney, yes, you may have some decrease in kidney function, but ultimately long term, you're probably going to still have a very full life, especially if you're not doing anything that will hurt the kidneys. The one kidney that you have left over tends to be able to pick up the slack and be able to filter through everything, process everything like it should. Again, there are cases where maybe they get more easily dehydrated. Maybe they get not able to metabolize certain medications as quickly as other people. Therefore, they become more toxic or have more side effects to certain medications. And so there are smaller things that can affect the donor, but overall, the lifestyle doesn't change very much other than just monitoring what they're intaking. They don't have to take any lifelong medications for it. Obviously, they have something good on their conscience, something that they did to help another life. But really, I think the biggest sacrifice is those initial first weeks after the surgery. They are going under, so there's always a risk of anesthesia. They're going under the knife, another risk with surgery, bleeding out, infections. But once they're out and in recovery and they're able to get past those first 3 to 4, even 6 weeks, it's usually pretty smooth sailing after that. But again, we're talking about someone that was super healthy prior to the donation, but anyone else that has had medical issues and then they're also giving an organ, then there's probably going to have more complications. So the scenario I'm giving you is for someone that is very healthy, starting from scratch, no medications, no medical history issues. That would be the ideal candidate.
Going back to the urban legend, right? I remember my parents telling me this urban legend when I was a kid. You trusted the wrong person. They drugged you. They put something in your drink. As we've gotten older, especially when we got into college, it was always, hey, always watch your drink, especially if you're a woman. Make sure nobody's slipping anything in your drink. You don't want to end up not knowing what's going on around you, and just make sure you always get home safe. This was always one that my parents used to scare me, where it's, hey, when you're out and about, be careful of who you're around and who you're quote unquote going home with and who you're surrounding yourself with, because you never know when you're going to wake up in an ice bath with a kidney missing. This goes to the fear of maybe a black market organ trade. And from my experience, I've never had to deal with this legally, but there is instances in which there is a criminal enterprise where things like this in some instance does exist. People do get trafficked for reasons. People do get harmed, and it may not be prevalent in our country, but there's other countries that probably deal with this, especially when you're looking internationally at other countries where the standards aren't really up to speed. I would assume that black market organ trade can really run rampant into areas where organs can get you a very, very pretty penny, and safety standards and medical standards aren't really up to par with us in the United States. Have you ever heard of anything regarding black market organ trade in the United States medical field?
I have not personally heard anything, but I do know of some cases in third world countries, countries where poverty is very impoverished and then the rich are very rich. And so the people who are trying to get out from the bottom, the only way to feed their family, to feed their kids, may be to donate an organ for a certain amount of money. And so you do hear a lot more of those cases in third world countries. Like you said, there aren't as many strict regulations and rules as here. There's not as many laws prohibiting it. And again, the people who benefit are usually the people who are paying the government already. So yes, I have heard it internationally, but not really here in the US at all.
Okay. And I think this is a good segue into our next topic, because the transition goes from, are you actually dead? So when you're looking at organ donation, people are very ignorant to what organ donation actually is. And I've heard time and time again, I don't want to volunteer to donate my organs because what if I'm in a heinous accident? What if I'm still alive? And now they're more worried about harvesting my organs as opposed to keeping me alive. So is there any worry about that? Should people be worried about that? Is that actually a thing, or is that just conjecture and people don't really understand the process?
People just don't understand the process. It's actually very hard to donate organs. Again, you have to have a very healthy lifestyle. Your organ truly has to be quite healthy to be able to give it to someone else. Because if we're going to do this big transplant, give it to someone else, and they're going to try to live with it for the rest of their life, then we want to make sure that that organ will last the lifetime. We don't want to be giving someone one organ and then 30, 40 years later have to find another organ donation again. So we want to try to make it a one-time transaction. Therefore, the person donating really truly has to be a really, really healthy individual. So even if you're coming in to the hospital and you're on your deathbed, depending on what you're there for, may immediately disqualify you from being an organ donor, even if you had volunteered to be an organ donor on your driver's license. So there are a lot of criteria that you have to meet. There are certain testings and labs that need to be passed before it happens.
That is super interesting. So essentially, I could be in a position where I have passed and I'm being transferred to the hospital, and I die en route, and it says that I'm an organ donation, or I'm organ donor. When I get there, basically me as a deceased individual, I'm going through tests to then determine if my organs are viable, if they're healthy, if they are actually worth using for donation at that point.
Correct. Because we want to make sure that you don't have any communicable diseases. We want to make sure you don't have HIV, hepatitis, any or sort of STDs, anything that could be systemic that could then be passed on to the recipient.
So how fast do you have to go at that point before the organs are no longer, like, I guess, viable to be used?
Again, I don't know the exact time. It might be shorter than 24 hours because if you think pathophysiologically, if your heart is no longer pumping blood, then it's not keeping the organs alive. There are cases where you could keep the patient on a machine to circulate the blood so that you have more time to do the testing. But really, ideally, you get it done in the first couple of hours.
It's very interesting. That's very interesting. That's a good segue into my next topic, which is safety caskets. So back in the 18th and 19th century, there was a fear of being buried alive. And obviously medicine has come a long way since then. But there was this fear of being buried alive in which people would start buying caskets where there may have been a breathing tube, there may have been a bell or a type of flag. So if they woke up in their casket, woke up in their coffin, and had already been buried, they could then ring the bell. And I think it's historically debated, but that's where the phrase "saved by the bell" comes from. So being buried alive is a fear for many, many people. As a physician, how do you guys accurately determine whether somebody is legitimately dead? How do you pronounce them dead? What's the process that you go through to make sure they are actually dead before you make that call?
Well, one, we go in and we ask them. If they say no, then probably still alive. I'm kidding. The important thing that we do is when we first walk in, we want to make sure that we are very respectful. And so we will go in, introduce ourselves to everyone in the room. We'll introduce ourselves to the patient as well, whether they're alive or not. And then we tell them this is what we're going to be doing is we're going to examine and try to see whether or not they are able to respond in any fashion at all. We'll run through our exam, but we'll also want to make sure we do a very hard sternal rub is what we call. That is usually the first thing we do is a sternal rub before we head up to the eyes, the pupils, then down to the heart and lungs. Usually a sternal rub will cause a reaction if if they had passed out or if they were, if there was any other reason for them to be out. That's not death. We start at the top. We look at their eyes. We check to see if their pupils are reactive, meaning if they're alive and they're processing, then if they see light, then their pupils are going to constrict. Whereas if there is no reaction at all, even to light, then we know that there may be some damage to the brain. Next, we go down to heart and lungs. We listen to their heart to see if there's any pumping. Is the heart still functioning? We listen for breath sounds. Are they still breathing, even if it's very shallow? We then go down to their arms and check for pulses. Again, making sure that there's not any sort of circulation of blood. We then go down to their abdomen, feel for any pulses in the abdomen because you have that big aorta that runs down, and you can also usually press around the abdomen to see if there's any pain reaction from the patient. And then finally you go down to the feet or fingernails or toenails, and you want to do what we call a pain response. Some people will either squeeze their nail really hard or roll a pen over their nail. And if you ever do that on a live person, it hurts a lot. And so if you do it on someone that is dead, there may be no reaction at all. So those are the couple of ways that we determine on a physical exam.
Are there any diagnoses that would mimic death? Is there anything that they may not be dead? It may just be they're in a coma or hypothermia or something of that sort.
I wouldn't say that there is any common diagnoses out there that would mimic death. There are certain instances that can cause death-like symptoms where the body shuts down for a couple seconds. Because again, if you think about it, when there is death, there's no circulation of blood. And if there's no circulation of blood to the brain, then things start to die off. So if you have no circulation for a very long time, and that I'm talking about 10, 15, 20 seconds, you start having brain cell death. So you start having the death of certain organs, you have dysfunction of the brain. That's how we have heart attacks and strokes. Essentially, a clot gets thrown into these organs. There's no circulation to that organ, therefore they start to die off very quickly. And we're talking seconds to minutes. So there's really not any diagnoses out there that I know of that are very common that would cause that. So it's really hard to mimic. I know we see a lot in movies, but for some for someone to be out for more than 5 minutes, even if they were not dead, they will be dead.
There's always that movie where it's a criminal making an escape where they take a chemical or a pill of some sort and it puts them in a state where everybody thinks that they're dead, and then they sneak out the morgue. And your first comment of me asking, how do you verify? And you're like, well, at first I asked them, I don't know if this was a lawyer joke or an actual event that occurred. But of course, jokes are sometimes based in truth. But there's a story in which a doctor is on the stand as an expert witness, and the lawyer is asking them questions to verify how that doctor determined that individual was dead. And so the attorney is like, well, doctor, we're here to determine how you pronounce that individual dead. So first, did you check their pulse? He was like, no, I did not check their pulse. Well, did you check their pupils? No, I did not check their pupils. Well, did you check to see if they were breathing? No, I didn't check to see what they're breathing. Well, doctor, how did you confirm that individual was dead? And the doctor responds, well, his head was sitting on the table next to me, severed from his body. And it made, the attorney look like an absolute fool trying to like pull one over on the doctor.
Right. Yeah, usually when I would say 80% of the time when you're going in to pronounce a death, it's because you already saw it coming. You already knew it was on its way. So beyond the physical exam, you're also following vitals, you're following lab work. All of those have signs, certain signs that will show you or indicate that they are very close to passing. Even their breathing patterns, the way they're responding or not responding to loved ones in the room. There's usually a very common timeline that a lot of these patients go through before they end up just passing. The one abnormal thing that I've seen time and time again is when there is a loved one trying to fly in from somewhere out of state or somewhere out of country, and the patient somehow knows or understands and just waits and waits and waits, even though they may have a diagnosis that we would have expected to cause them to pass in 12, 24 hours or even less. They're somehow able to hold on until literally that one family member that they've been waiting for comes in, says their goodbyes, and then they pass. So I've seen that scenario a lot. Another scenario I've seen is where all the family members are there, constantly taking turns to watch over the patient, and they're hanging on. I've had patients hang on for 5, 6 days, and then all of a sudden, whatever it may be, whoever was supposed to be on standby ends up going to take a break, whether that's lunch, whether that's to the bathroom, and those 5, 10 minutes where the patient is alone, it seems the patient takes that opportunity to then pass on, because we usually, unfortunately, we usually end up going in to check on these patients and we find that they have already passed, and therefore we usually have to go run and find the family members. But those are the scenarios that are a little eerie to think about, or wonder how these patients either know it's coming, trying to wait it out. It's hard to understand, but I wonder if there's anyone doing any research or data gathering about those sort of scenarios.
I've also heard situations, and of course, you're the doctor, correct me if I'm wrong, but situations in which the individual might say to the person who's passing, it's okay. Like we're going to be okay. Like give a final goodbye, and it's allowed the individual to finally like go at peace, which again, a little bit eerie, very spiritual. And then the other one that I've heard of is like if a person is going towards passing away, all of a sudden they'll have all the energy in the world and people will start thinking this person is actually going to make it, like everything's going to be okay, and the hospital staff sits back and they're like, that's actually what's expected right here. Either one of those things commonplace?
They are both, yes. Again, death still has a lot of unknowns, and we're still trying to figure all that out. But yes, I see those sort of things quite often, even in my very short career as a doctor so far. I can only imagine how much more I'm going to see down the line. And it's very intriguing to see those sort of interactions, but also to be able to see how families and patients interact, but also process what's going on, the news, the information, and just the passing in general, the death in general.
And this ties into, some of our other podcasts where we're, talking about power of attorney and wills and so on and so forth. So if you want to learn more about powers of attorney and wills and how to put your family in the best possible position, if anything horrible was to happen, please go and listen to some of our other podcasts. Well, that brings me to the last topic, which I feel might be right up your alley. We've talked about the difference between MDs and DOs. And as a DO, please remind our listeners what you focus on as far as trying to treat your patient.
As a DO, we are taught how to be very holistic. So we look at a broader picture, not just the specific ailment. You come in with shoulder pain. Yes, we're going to focus it on the shoulder and try to figure out why we're in pain. But then we're going to talk about how do we prevent it in the future. But also we want to try to figure out the mechanism that caused it in the first place. Are you swinging your arm in a certain way? Are you doing something repetitive that's causing it? Or maybe a certain muscle group is weaker, your triceps weaker, or your deltoid's weaker, and your trapezius is weaker. Maybe we need to focus on building up those muscles to prevent injuries in the future. So we're always looking outside the box, but we're also utilizing traditional medicine to help try to improve and optimize your body and health. And so that's the one difference that osteopathic physicians bring to the table. Of course, nowadays, a lot of physicians and a lot of schools have gathered and taken from both sides and cultivated to this melting pot nowadays.
Which is a great segue. So our final topic is about witchcraft and voodoo and potions and whatnot. So with it being Halloween, the creepy, the eerie, you look at a witch and what kind of potions she's brewing. You look at Hocus Pocus and they have that big old kettle and they're brewing something to make sure that they stay alive forever. And when you look back historically, a lot of remedies had to be based in natural things, whether it is vegetation or certain animals or fruits or veggies or whatever it might be. And so it's really easy to look at cultural practices like something like voodoo, in which you're trying to put together a potion, quote unquote, a potion, something that is a remedy to give to somebody for a sickness or for something health related. I think that some of these individuals were generally considered community healers. You would go to them to look for help outside of a traditional doctor, whether or not you actually had access to a doctor or whether you didn't trust the doctors in your area. Or if you're going so far back, culturally speaking, there may have been a divide where you couldn't go to the doctors in your area. So when we're looking at modern drugs and non-traditional or more holistic approaches to medicine, do those exist? Do you ever say, hey, I don't want you taking Tylenol, I don't want you taking this, I would prefer that you take this instead as more of a natural remedy before we get to the hard prescription?
It depends. It really does depend. I do feel a lot of modern day pharmaceuticals have a foundation in natural herbs, supplements. It comes from something natural that they have then modified and improved and advanced to a point where it no longer looks the same as it used to, because we're trying to optimize and if make it more efficient, right? We're taking some of the great properties of this natural thing and multiply it by 10 so that we have a better effect. So I do think the majority of pharmaceuticals come from those. But you're right, there are certain supplements and medications that we do utilize, or at least comes out in public as something that we can commonly recommend. It's not usually something we would prescribe. It really depends on the patient. If a patient comes to me and I get the understanding or the vibe that they are wanting to be more natural, then I have certain things that I can recommend. It always comes down to lifestyle changes, right? diet, exercise, weight loss, food choices, portion sizes, those are always the natural options. But if they're looking for supplements to optimize, then we try to go, again, evidence-based. Anything that has shown a lot of evidence out there and a lot of research, we try to stick with that. So we know that vitamin C, zinc can sometimes boost the immune system. Other natural anti-inflammatories, we have turmeric, we have honey. Those are things I recommend, especially for kids or pregnant patients who are more limited on certain medications that they can take. Therefore, I will say, let's do, a tablespoon of honey as long as they're over the age of 1. That can help with sore throats. That can help with viruses. If a pregnant patient is nauseous, we usually go with ginger. And then if ginger doesn't work, then we do pharmaceuticals. So yes, there are a lot of things out there that we still utilize. And of course, the witchcraft and potions, that's tongue in cheek, right, for our Halloween episode. But a lot of it we call non-traditional medicine, or we call it Eastern medicine. Other things that are interesting is actually from my Asian background. We do a lot of cupping, a lot of coining, even a lot of acupuncture. So those are all things that a lot of Eastern medicine or a lot of people in Asia will utilize. I personally utilize some of it, and it personally does help. I wouldn't say that it cures or treats anything, but the placebo effect is strong in a lot of those modalities.
I think that we can really dive into those non-traditional approaches in another podcast. But for the listeners, a lot of people understand what acupuncture is, and some people have seen like the athletes do cupping. Coining, I've actually never heard of. Can you give like a quick 10-15 second rundown on each one of those non-traditional approaches?
All these modalities, we're basically using a different type of tool to help release certain stress points or chakras or energy facilities. For acupuncture, we usually think of the needle. We are putting needles in certain areas of the body to help release the bad energy, the chakra, or undo a certain knot that we may have in the body. Again, this is why it's not something that we utilize on a day to day here in the US, but is commonly used over on the other side of the planet, mostly in the Southeast Asia areas. Another modality would be the cupping. Again, that's supposed to help pull out some of that stress, that dark energy. And what you do is you use these cups that will then, you heat it up and it will then suction out. And that's what leaves the dark bruises on people's backs or shoulders that you can sometimes see. The idea behind that is it's supposed to draw blood and fluid and all these healing properties specifically to that area where the cupping is at. So we tend to think that it may be good for improved healing, for muscles, help shorten recovery times, enhance performance. So those are some of the reasons why we use the cupping. Coining is even more interesting because you literally use a coin. So something like a quarter or a nickel. And so you basically follow the lines of your ribs and your spine. And so you're going up and down and you're rubbing on your back, up and down, off to the ribs, and you create these lines very similarly to the cupping, but you essentially cause these bruises, striations on your skin, which then helps bring blood there, brings fluid, brings all of these cells that come naturally to help repair that area, which then ultimately is supposed to help release some of the stress and the illness that you're going through. That's something that I actually utilized a lot as a kid. And I will have to admit, every time I got coined, it felt really good the day after. I don't know if it's because the coining itself is really, really painful if you're not used to it, and it was a placebo effect, or if it truly was doing something. Again, depending on how you grew up, where you grew up, and whether or not you were exposed to these things, sometimes they are more helpful than not.
I've seen a version of coining with some athletes where they're taking something that almost looks like a spoon and digging along the muscle lines. And after they're done, they look bruised. They look completely bruised and battered. But apparently that's, I guess, a very similar thing to coining.
No, that's exactly what coining is, except they're using the edge of a spoon, but same
Gotcha.
idea.
Same idea. Okay. Now, taking it back to the eerie and the spooky, when you're looking at Eastern medicine or non-traditional herbal remedies, Native American remedies, the witchcraft, voodoo, what have you, it's pretty easy for an individual who's going the non-traditional path to be deemed somebody that's out of the ordinary. It's really easy to look at somebody who's putting together herbal remedy and saying that's a witch. We don't do that around here. But I think that there's also the notion of you're using very natural remedies from the earth. There's a way that you could probably really hurt somebody. You could actually poison somebody. You could actually kill somebody. There's a garden in the UK that's the death garden, and it's everything in this garden can kill you. If
Hmm.
you ingest it, if you touch it, it can absolutely kill you. there's definitely some risk and liability for anybody putting together an herbal remedy and using from the land. Like I was a Cub Scout, one of the first things that we were told, do not put any berries in your mouth, do not eat any of the mushrooms. You might die if you do any of these things. So to have to utilize these remedies, you probably have to be very, very experienced. And then there's probably some trial and error that's passed down from generation to generation to make sure you're not killing somebody.
That's pretty much the same process that goes on for some pharmaceuticals. They just do it in a lab versus a day to day out in nature. Same idea is that you find these certain medications, you work through the properties, you figure out what the benefits are, and then you do it in certain doses and you try it on certain people. And then you do trial by error.
I've actually never thought about it that way. Like pharmaceuticals is kind of like modern day like witchcraft, like modern day witch's brew. They're combining chemicals and obviously using it on like test animals at first, but you're trying to see what causes what, which is a unique way of looking at it. A very unique way of looking at it.
And they just know how to make the profits, though. They just know how to
Yeah.
take all
Yeah.
our money.
I appreciate your insight, Dr. Long. To bring it back to Halloween, you got any plans for Halloween? Any traditions that you guys do, or are you planning on trick or treating? What's going on in your household?
You know what? I am actually not a big fan of Halloween. It's a little creepy that everyone likes to pretend to be someone else during Halloween, but I do love the candy. And because we do have two young ones, this is actually going to be our first year that we're going to dress them up and go out and trick or treat for them and just allow them to enjoy the festivities and enjoy being kids. But not my most favorite holiday. I prefer Christmas or Thanksgiving over Halloween. But Nick, I think you're pretty big into Halloween.
I absolutely love Halloween. It's one of my favorite holidays of all times. I insisted that we have a Halloween podcast, and Long was like, "Well, what are we going to talk about?" I'm like, "I have ideas." But I decorate the front yard. Luckily, my wife also really loves Halloween, so we've been decorating all month. We put up the skeletons and the lights, and we have the pumpkins, and it's just a fun time. I've always enjoyed it. I've always enjoyed scary movies. Unfortunately, my wife does not like scary movies, so we have to pretty much stick with the Disney Plus movies, or I have to watch the scary movies by myself. The most exciting thing about us finally having our little girl when we do is that she'll get older and then we'll be able to take her trick or treating and have that childish experience with her. And that's not just for Halloween, that's for Thanksgiving and that's for Christmas as well. All the fun holidays and just being able to look at it from the viewpoint of a child again. So we're definitely looking forward to that. What are you guys going to dress the little ones up as?
So our son's gonna be a dinosaur, and then our daughter is a little toucan or a little bird.
Well, that's awesome.
Yeah,
Are you guys dressing up or are you and your husband dressing up at all?
I'm not too
No.
old, too old, too cold. No, thank you. We'll let the kids have fun being kids, and the adults do their adult things.
Around here, our neighborhood is really big on Halloween, and the way our driveways are, they're longer driveways, so everybody sets up a fire pit. And we're in Texas, so the weather's still beautiful out. But everyone sets up a fire pit, sets up tables, and so all the kids and all the neighbors just get to walk around and see each other, and they'll have a beer in their hand while their kids are walking around, going from house to house. So it's kind of a social event. So we're really looking forward to that. My parents come over, my brother and sister-in-law and their kiddo, my nephew will sometimes come over. So we're really excited for it. But I do know that the request from the pregnant wife has been made that on November 1st, it is no longer Halloween in our household. That baby might come out at any second. So now it is Christmas. There's no question about it. It is Christmas now. By the time we air this, I have 24 hours. This stuff needs to be taken down.
You better hope baby doesn't come that night of Halloween.
Oh, and we were at a wedding last night, and one of our friends jokingly said, "You guys love Halloween so much that her water is gonna break on Halloween. You're gonna have a Halloween baby." I'm like, "Please, no, no. I'm still working on this nursery. Let's not."
Well, that's a great, it's a great place to end this episode of the Medical Legal Brief, where medicine meets law. We appreciate you joining us here with Dr. Long and lawyer Nick. If there are any topics that you guys are interested in hearing about, we would love to research and talk about it. So please like, share, follow us. We are on Spotify as well as YouTube, but we're also on Instagram and TikTok. So follow us wherever you may want to. But until next time, we appreciate you tuning in.
Happy Halloween. Y'all be safe.
Happy Halloween.
Yes, we're doctors. Yes, we're lawyers. No, this podcast is not medical or legal advice. Do not take anything we say as a reason to perform your own heart surgery, represent yourself in court, or diagnose your neighbor's rash. This is for entertainment only. Think of it like hanging out with your smartest, wittiest friends, not a substitute for an actual appointment. If you act on anything we say without talking to your own professional, that's on you. Seriously, don't do that.